Is Dr. Beth Mertz. Dr. Elizabeth Mertz is a professor at the University of California, San Francisco, with a joint appointment in the Department of Preventive and Restorative Sciences, School of Dentistry, and in the Department of Social and Behavioral Sciences in the School of Nursing. She's affiliated with the UCSF Center to Address Disparities in Children's Oral Health, the Can Do Project, the Philip R. Lee Institute for Health Policy Studies and Healthforce Center, where she has worked since 1997. Dr. Mertz has researched, published, and lectured on a broad range of healthcare workforce, health policy, and health services research topics, including the supply and demand of providers, health professions regulations, state and federal workforce policy, access to care, oral health disparities, and evolving professional practice models. She holds a BA from the University of Southern California and a master's degree from the Humphrey Institute of Public Affairs at the University of Minnesota, and a PhD in medical sociology from UCSF. Dr. Mertz's presentation is titled Role of Oral Health Workforce in the Healthcare Value Equation. Please join me in welcoming Dr. Elizabeth Mertz.
How's everyone doing? Are you digesting? Everyone's digesting. Do we need like a stretch or something? Feeling okay? I need a stretch. All right, so workforce is clearly a non-controversial subject. So I'm just gonna tackle this one head on. You guys ready? All right, how do I do this? All right. So what I was asked today to talk about was sort of where we're at with the workforce in the context of where we're at with the change to these value-based payment models. I know more about the former and less about the latter, but I'm going to do my best to put those two together. Because we don't have a lot that's actually happening, you're hearing a lot of case studies and a lot of examples in this forum over the next couple of days. A lot of what I'm going to be talking about really is sort of food for thought, so as opposed to direct empirical evidence of actual things that have happened. So just that caveat. I have no conflicts of interest, and I take responsibility for everything. So the learning objectives today, I'm going to do a little bit of a dive into sort of some of the drivers that I think are important to get us to where we're at. Talk a little bit about the historical element of this divide, this medical-dental divide. Talk about the organizational approaches that have been used, then get into some of the workforce implications. And then I have one case study off of some of the research I've been doing up in Oregon that I will be presenting at the end, because I actually think it's a nice example of the way that you can coordinate around systems. So let's just start with a few context and definitions. So I think I'm the first person to actually put this slide up in its entirety, even though everyone's talked about it, so yay for me. I was sure this was going to be a repeat. But essentially we've got the triple aim. This is really what's driving all of these things, trying to reach the triple aim. And we used to think about cost, quality, and access as the key important things around health policy and driving systems, but those were always trade-offs, right? If you wanted to decrease cost, you were going to have to decrease access or decrease quality and vice versa. And really when ISI and Don Berwick came out with the triple aim, the idea was to make it a single end game, so that you weren't doing these trade-offs, but that the goal was to reach the triple aim, you have to do all of these things at the same time. So the per capita cost of care, the experience care, and population health. So cost, quality, and access are still in there. They're just reframed in a way that we can drive towards that aim without the trade-offs. So 10 or 15 years after the triple aim, one of the things that we realized is we were just burning our workforce out, because everybody was trying to reach the triple aim, but nobody was paying attention to health and well-being of the workforce. I think this is really important when we've heard a couple of things about lessons from what medicine did before, lessons from what the health system has done before, this issue of physician burnout, provider burnout, and the negative impacts that actually has on bottom line, on cost, on quality, on the patient experience is really important. So I try to think now in terms more of the quadruple aim, because I actually think if you think about that, labor is about 80% of the cost of healthcare overall. How we take care of that labor, how we take care of our people says a lot about how we're going to actually achieve those health outcomes. So now let's talk about the value equation. So that's just the context. That's kind of like what got us to why we are even having this conversation. So then in the, and I pulled this from a nice site in, at the University of Utah. So they have this idea that there's the value equation itself is health outcome achieved per dollar spent. So it's a pretty easy equation with a lot of complex parts. But the hypothesis underneath having this value equation is that if value improves, then patients, payers, providers, and suppliers all benefit. At the same time, the economic sustainability of the healthcare system increases. So it's easy to say that, it's very hard to achieve it. So Porter in 2010, when this was out of the New England Journal of Healthcare, sort of outlines what the equation principles are. So how do we break this equation down into its parts? So first of all, it's defined around the customer. It depends on results, not inputs. So that's why you have to have your health outcome measure, not just your process measures. Although the process is important, we're shifting from how much you do to the importance and quality of what you do. And the outcomes are really condition-specific and multidimensional. So in the equation, an outcome is represented by quality of care and patient experience. So it's not just the clinical definition of quality, but actually the overall experience of policy. And usually, and we've been moving to this, we've been seeing folks moving to this in medicine and maybe not so much in dentistry, is this idea of adherence to evidence-based guidelines, so that you know you're doing the best for your patient if you are following the evidence-based guidelines and then adapting them to the patient's preferences. Most of this is really on care process. And then finally, the cost that is that the numerator or the denominator? Anyway, the one on the bottom. I did take econometrics. The value for the patient is created by the provider's combined efforts. So this is kind of the idea of looking at the overall value equation. So then now we ask the question, where does the workforce fit in this? Where does the workforce add or detract or connect to this value equation? So I found 3 places just in this. So the first is the volume to value. So this is really a shift in production. So a shift in kind of the outcome for the workforce, what they're being rewarded on. The second thing is really what is the work that they're doing? So are they doing something based on their history, their experience, based just solely on that person, or are they utilizing the best science and evidence and using clinical guidelines to actually drive towards the not just the individual population health or individual patient's health, but the population health? So the shift of how they do it, what they do, and then how the work gets done, so the teamwork. So really looking at moving towards more collaborative team-based models. So if we're looking at this value equation and we're trying to dissect, okay, where does the workforce fall? What do we care about in terms of how we use our workforce, how we train our workforce, what our workforce is doing? And there may be other places that you could pull this out, but these are the main things that I pulled out that would drive us to thinking about, okay, what is it that we really care about? So now, let's talk about value in dentistry. And I'm just going to take you back to a little history lesson here. Something you guys, it's not really history, it's still present day. But we have historical separation for dentistry across all these different sectors. So our workforce and education systems are different, our delivery systems are separate, our insurance design and coverage, it's not really even insurance, is different. Federal and state policy is different. So we do have, some instances where we have dental combined into these broader things, but generally they're separate. Even scientific discovery and research tends to be segmented. And then certainly, as we've heard multiple times today, the technology and infrastructure is entirely different of the things that we use. So some would say, well, dental is different. This is the way it's always been. Doesn't really matter. We can just, fix it. The problem is a problem of externalities. So if any of you have taken an economics class, there's this idea of externalities, which means that there are upsides and downsides to a system process that happen outside the system. And those externalities are really important because those are the effects. If you drive your car and the externality is pollution, you're hurting people. You didn't hit them with your car, but you're hurting them based on the pollution that you're putting into the air. So it's an externality of the choices that we're making. The problem with the medical-dental divide is that these externalities are massive. So on one side, we have a dental system that doesn't see, 30% of the population of the US. What is the downside to the dental system of not seeing those patients? Nothing. There is no downside. You bear no risk for those people. They show up in the emergency room, they cost the medical side, or the patients themselves suffer. They're not your patients, who cares, right? Downside risk to doing nothing is nothing. There is no downside risk to the dental system for doing nothing. Huge externality. On the other side, the upside risk, the reward for doing more, the reward for medical dental integration, the reward for all these lovely things that we just heard Patty talk about. Who gets that? Is there a reward to the dentist? Does the dentist get a reward? No, that reward would go to the patient for being healthier, or that reward would go to the medical system for saving money. So you have this separation with these huge externalities that creates a system where there's literally no incentive to do the right thing. We know what the right thing is. No one's incentivizing us to do it. Pilot projects, NIH grants, okay, maybe there's some of those things, but like from a systems perspective, that incentive is not there. I just want you to keep this in mind, because when we talk about actually what these things might look like as we go into what value-based payment might do in terms of the delivery system design in the workforce, we always come back to this of who's in the game, who has skin in the game, right? And I think that's really important. So when we talk about the value in integration versus separation, we've talked a little bit about what the integration is, this promise to sort of improve the patient experience, do better screening and referral and coordination. And we have a few good models of that, but really it's a hypothetical value at this point because of those two externalities I talked about. What we really see a lot of is separation, continued separation, where the dental system says, oh, hey, they're doing that in medicine. Why don't we try that? Why don't we try that over here in our dental system? Okay, and then you can replicate those things, but it never really truly addresses those core externalities, which are the fundamental thing that is driving no system change going forward. So, I'm gonna give you a couple examples of this. So when we think about in the health system, we're trying to move towards this value-based system, move towards pushing these outcomes. The fundamental thing, so the payment system, even though in dentistry, a lot of times you think, oh, well, the payment drives the provider's behavior. The reality is the payment drives the organizational design that drives the provider's behavior. Providers don't work directly for payment. They do in little solo practices, but even a solo practice is an organizational design. That is an organizational setup that you have to have. So when you think about what has happened in medicine, we've seen sort of three big changes away from that solo fee-for-service with the hospital rights to these larger models. The first one, and this sort of predates actually the Affordable Care Act and some of the value, what we now call the value-based payment, but is really looking at the chronic care model to, and this is when we sort of saw the shift from acuity towards chronic care being the big thing that was driving disease patterns in the United States, and really trying to figure out how do we get out of the hospital-based acuity model into something that's much more of managing chronic disease. So we see this move towards a chronic care model. So is dentistry included in this? Maybe it is. I mean, some people say it's infectious, some people say it's chronic. You guys can fight about that, you're clinicians, I'm just a sociologist. But what we do see is, we do see examples. This is from just a paper I found from Bert Edelstein. But you can replicate the chronic care model from a disease management process in medicine. You certainly can, and people have done that before. But I haven't seen where it's been integrated into the chronic care model. It's just been replicated. So again, separation versus integration on the policy front. We heard a lot this morning about patient-centered medical homes. A medical home encompasses these 5 functions. This was one of the key things that was sort of in response to needing to drive this value and being able to really push towards outcomes and risk stratify and do the things around within a more patient-centered thing. Well, I'm sure you've all heard of patient-centered dental homes, right? We have the same thing. For a long time, the patient-centered dental home was really just code word for a dental office. You need to go to the dentist. And then finally someone came up with a definition, which is great. It's really funny. It looks a lot like the definition of a patient-centered medical home, just saying. It kind of has all the same attributes, but except for it just has that one word that's dentist, right? Dental is separate. And I'm not, Damiano and the group in Iowa, they did a great project, it was a great job. Maybe it will form the basis of this, but I also think it's another example of how we take an innovation in medicine, and rather than jumping into it and integrating it, we just replicate it over here in the dental space. And so we replicate that process of a lack of integration, which then replicates the process of not dealing with those externalities. This is just, again, I thought it was interesting here, the measure is the population who received care. So this is our HEDIS measure, right? Annual dental visit. That is not a quality measure. That is what happened to that person when they went into care? Were they high risk? Were they low risk? Did they get an appropriate diagnosis? Did they get the appropriate treatment? Were they overtreated? Were they undertreated? Did they come back the next year? We don't know any of those things from a HEDIS measure where you're saying, okay, here's just, they showed up. Great. And then the third big organizational redesign are these accountable care organizations. We also heard about that this morning. Obviously, you could sort of think of a dentist as a specialist. That certainly would, there are whole countries with stomatologists that work under that model, so it's not crazy. But that certainly is not what we're seeing happen in the dental world. In the ACOs, I did a literature review on this. I found a lot of thought pieces about how important it would be to have dental be part of an ACO. That's great. They were really nice pieces. But we don't have an integrated health record. We can't really do it. Too bad. So as of 2016, the only survey I saw of this was one that came out of the HPI, where they showed that only 14% of the ACOs had any responsibility for dentistry. And the data that they presented really showed that those were more likely than not in hospital settings, and they also were more likely, the middle part where they also had vision, hearing, speech, and mental health services. So this would be an ACO that's already looking much more comprehensively, and they thought, oh, we'll add dental in there as well. But overall, the data is pretty low in terms of the way, and I haven't actually seen, I will admit I didn't spend hours on looking for it, but I haven't seen an actual study that has shown clinical effects over time of these types of arrangements. So, all right, so we started out, we know what's driving it, we're trying to get to the triple aim, we know we have this problem of being separated, we know that there's this organizational design piece in the middle that's really important to getting us where we need to go, because healthcare providers don't work in a vacuum. So when thinking about, okay, what is this gonna look like? First of all, let's talk about the value-based pieces. So, and somebody else earlier showed this slide, but I'm going to just walk through it really quick. Sort of 4 categories that are thought of in terms of the way that the payment system would drive the design system that would then tie to the workforce. So the first one is fee for service. We have that. The second one is fee for service linked to quality and value. Essentially, you have a fee for service system where you add a reporting requirement or maybe a pay for performance requirement. Then you can kind of move to, there's a third category where it's alternative payment mechanisms. This has upside and downside risk. So either upside risk for not achieving health goals, or downside risk if you don't achieve this. So either you get a bonus or you get a fine. And then finally, population-based global payment models, which really is per member per month. You can do this, the traditional HMO or the original version of the HMO was sort of this, but without any link to quality, and the current versions are much more linked to quality and outcomes around specific evidence-based guidelines. So let's think about this. If we're going to redesign our workforce, we're going to think about how to retool our workforce to work in a different organizational design. There's a lot of different ways of it, and this is just, I put this together, I literally made this up. I'm just so you know, this isn't evidence-based. I mean, except for the evidence in my head. But I thought it was useful to think about how to think about it, right? So you could have dental only, you could have a dental medical integration, or you could try for a broader social health integration, something that has social health and public health and social services and all the things that we know are actually important to the patients that have the highest risk and the highest need. And then you've got your kind of payment structure across the top. So whether it's fee for service or global budget or what have you. So if you just start with where we're at, which is dental only in fee for service. So do we need a workforce redesign in the dental office? I'm not talking about population health. I'm not talking about delivery system. I'm talking about in the dental office itself. I mean, they kind of got it dialed in. Like, they know what they're doing. People come in, they do the fillings, they leave. So it's not a whole lot of thing there. If you wanted to integrate with medical, but not change the payment structure, you just need a better referral system. You need to know who the dentists in the community are, so when you have a problem, you can move it out. And then the same with the social and health piece. But as you go through the other things, there's lots of things that you might want to think about. And I'll just use, I'm not going to go through all of these, but in terms of just moving to sort of level 3. So level 3, and I say L2 because I sort of capture that level 2. So if you're going to just stay in the dental space, but you really wanted to report quality, maybe get paid for quality, and then maybe take some risk for the quality that you're getting paid for, you're going to need a different workforce to achieve that in a different organizational setting. You're going to need clinical management. It's not just patient management at the clinical level, it's actually clinical management of the practice and the provider. You're going to need IT for data capture. You're going to need some sort of central administration that helps to coordinate these things. You're probably going to get bigger. You're probably going to need some lawyers, and you're probably going to need some care coordination. And so this is just a thought process to think if you really want to move into a different, it's not just about tasks and providers and who's touching the patient. It's really organizational redesign is what you're talking about. And that's within a different organizational structure is the only way to actually retool the work. So we think a lot, at least in the workforce setting, we think a lot about the clinical workforce and scope of practice and state practice acts and the various things about that. But I actually think if you're really trying to move up the value equation, you have to think much more broadly about who's involved in designing and running that organization to enable the providers, the clinical providers, to maximize their utility so that other folks can, and then other folks are doing more of the strategic management. So I'm going to go on because I'm going to continue this in the next couple of slides. So if we're thinking about a workforce transitions in dental care, just dental, let's just stick in the dental space. So if we really want to go from a small fee-for-service to kind of a global payment, I'm using an arrow here just because it's the 2x2 chart, but I actually don't think that this is necessarily a linear transition. I don't think that it's logical that we go from one to the next to the other. I'm just putting them there sort of more in that this would be a continuum of ways to think about it. But if we're going from the small independent to large integrated along the bottom, and then sort of a solo to a multi-specialty along the top, that kind of is going to get you a little bit, I think, conceptually from that small office to that bigger, something that might work under a more global payment system. So if you're moving from small to large and integrated, again, you're going to need strategic management. You're going to need people, leaders with vision, with the ability to lead people and get over some of those interprofessional humps that we have talked about. So that's going to need to happen. If you're moving from single to multi-special, you're also probably talking about operational scale. So you're not just talking about, 1 or 2 chairs in an office, but you're really talking about throughput that would support that size of an operation. And in the middle, you're really going to then need more clinical coordination. Now, this might be people that we already have. This might be new people that we don't have, or new skills for people that we already have. But these are the conceptual ways to think about it when you're thinking about what is the impact on the workforce? What do these redesign efforts mean in terms of the overall workforce? Oh my God, you guys are tweeting about me. This is so cute. So I was just checking the time. I also think here that we have to ask ourselves the question about where value's added in one session versus value added in another area. So value-added practices that are just dental only, do those same practices add value when you integrate with medicine? And do those same practices add value when you're in an ACO and working with social services? I don't know. I haven't done that thought process, but I think it's really important when we're thinking about investment and where the end game is. Are we going to invest only in dental system changes, only in that siloed dental system changes, just to see if we can move that ball, if those changes themselves are actually going to undermine our capacity to add value at some of the other levels? So I think you really need to think about this from a bottom up to, where is it that you actually want to go? Because I think there's a huge amount of so much potential for innovating just in the dental space. I mean, really, there's a lot of potential there. But if what we really want to get to is interprofessional, this larger value added to deal with those externalities I talked about, I think you're going to have to rethink it from the top down and where you want to go. So Now let's talk about dental providers. So, and I'm going to sort of fit this into the model, but first I'm going to sort of go through what I think of as these emerging dental care providers, for lack of a better word, not dentists, hygienists, and dental assistants in the traditional space. I'm just going to make a pitch here to please don't ever use the word mid-level provider. Just call them what they are. I don't call my children child 1 and child 2 or the small one and the big one. I use their names or something else. But I think that it's important that these are providers that have earned their stripes. They've gone through education programs. They have titles. Let's use those titles and not just put them into a hierarchy. So dental therapists, we have multiple different versions of that are going around the country. I think we just had Arizona and Michigan pass laws. So that's added to Maine, Vermont, Oregon, Washington, Minnesota, and Alaska that we now have practicing, and we have a dozen other states that are looking at this as well. So this is certainly something that we could see as a player in this organizational and practice redesign in the future. We heard a great presentation earlier about what's happening with dental hygienists. In California, we have alternative practice. One of the big places they're going into is long-term care settings. We have what's happening in Colorado, and there's a lot of other places where that direct access and the lack of, or the lower level of supervision really allows them to go into community-based settings. Again, moving sort of into the public health realm out of just the clinical care realm. Extended function dental assistants. I think in California we have 13 different levels of dental care provider now. But again, sometimes this gets us like pretty close to a dental therapist, honestly, in terms of scope of practice, but really being able to do more for the dentist, more for the clinical team, being more efficient in the particular setting. And then we have community dental health coordinators, also community health workers, also primary dental health aides, all sorts of lay entry-level type workers. Is anyone drank out of this, or can I have this? All right, whoever has germs, I'm getting on. It's either that or I'm just gonna go through the rest of the process like this. These are folks that are really getting out of the dental office, getting into the community, doing health education, doing referrals, really kind of linking patients that haven't necessarily been linked before back into the system. And then, of course, we have primary care and medicine. We got physicians and nurse practitioners and PAs, all those folks doing fluoride varnish and oral health education and referral and all the things we just heard Patty talk about. And then we have public health. I'm not forgetting about you guys. We have the public health folks that are out there doing program administration, doing, working with high-risk patients, doing all the things. We got public health nurses. We have hygienists working in this space. So all of this together really constitutes the folks that are focused on this issue, this epidemic of oral disease that we have, and this complete lack of attention to this huge swath of the population that is suffering the downstream impacts of this. So what if we took all these folks and we stuck them back in that same workforce, and instead of saying workforce transitions in dental care, we called it workforce transitions in oral health care. So again, we have here, I think we have to change our parameters a little bit. So instead, really at the bottom, we're moving from clinical care to more public health. And on the side, we're moving from just a dental only to much a more interprofessional model. So sort of changing the frame a little bit, I think, first of all, just to even incorporate what these broader issues are. So if you think about dental therapists and FDAs, really they're still in the dental only realm, but they're clinical care. So they'd be down there in terms of incorporating these new providers. You've got public health hygienists that maybe is a little bit more interprofessional, a little bit more public health, depending on the setting. You got community health workers, again, moving much more into the public health realm. Still, maybe tied to dental, but maybe tied to a new model that's emerging. You got your dentists and specialists. They're still obviously mostly in clinical care. They may or may not be moving up towards more interprofessional, depending on the organizational setting. You got your physicians and nurses, and then you've got this desperate need for care coordination. So now you have all these different systems that are working together, folks doing things at different levels. How are we going to coordinate this care? How are we going to know if they got a sealant in the dental school program and now they're not supposed to get one in the dental office? How are we going to know if somebody has diabetes and they need to be seen in this particular other setting? So right now, what you see is some of this happening in the dental office, but it's an add-on to an existing job. It's not an individual skill set, and it's not being done in a very comprehensive way at all. So I think that's an overarching workforce transition or workforce redesign is like, where's that care coordination going to happen? How's it going to happen? Who's going to do it? And what are going to be the parameters of that job? The second thing that I needed is this IT, the management and the leadership skills that really are necessary to go from, essentially a cottage industry to a large integrated health system. So you can't take a dentist that's worked in a small solo practice, then all of a sudden put them in charge of, a multi-site, multi-million-dollar organization and expect them to be successful. That's unrealistic. So they might be successful at doing their job, the clinical part of that in that session, but we don't talk about this, that these organizational systems, Kaiser didn't just happen. Like it grew, and then even the dental organizations, whether it's, Willamette, which I'll talk about a little bit later, or any of these large DSOs, you're really seeing, actually, no one talks about this. There is clinical management, clinical leadership, and it's not just IT people who make your computer work. We're talking about sophisticated data analytics, people who can mine electronic health records, who can give you population reports, that can actually work off clinic decision support and drive clinical decision making. So that's the kind of talent that you're going to need in this redesigned system, not just the providers. So that was my clue to myself, that little, So if you Google FFS, something comes up and it's not fee for service. And I think it's really appropriate here because, for goodness sake, this is that bottom left corner, that clinical care dental only, is where everyone's paying attention. Everyone's putting millions of dollars into who can do what and blah, blah, blah. If you put it in the broader context, it's like navel gazing. Like literally, not only does it not matter, second, you are taking away the tools that you need that will form the basis of the workforce for the future by limiting innovation, by limiting new provider types, by spending all these millions of dollars on scope of practice battles instead of figuring out how to move up the value equation, how to actually get the damn IT infrastructure and the diagnostic codes in place so that you can work on an integrated medical record and actually produce outcomes. That's where we're supposed to be going, right? Thank you. So why are we not going there? All right, so we talked about the medical dental separation, right? I'm gonna call that field isolation. Field isolation led to professional dominance over policy. The #1 funder of all policy making, or all lobbying around policy making, is organized dentistry, around oral health. That has led to a staunch preservation of the status quo. The status quo has worked for a very long time, and so of course it will continue to work, and so we should just argue that what we have is what we need. How many of you have heard American dentistry is the best in the world? Yeah? Oh, I've heard it. I want to think that. Show me the money. Like, what do you mean is the best in the world? By what measure? By your income? That's not that's not the population health outcome I'm looking for. By your tooth? Okay. So anyway, this preservation of the status quo has really led to this ideology or built on an ideology that professional training is the only indicator of quality. So if you do not have a DDS or a DMD behind your name, you're bad. No hope for you. The problem is that we've moved into a world where that's, one, not true, and two, where we have clinical outcome measures and clinical processes that could be distributed democratically through a team and would produce the same outcomes because they're evidence-based. Really focusing entirely on maintaining the boundaries, those professional boundaries, has also led to complete resistance to systems of accountability. What do you think value-based payment is? It's one giant system of accountability, is it not? Yeah. So of course you don't see dentistry jumping into this because they don't even want to admit that someone else can do a filling, much less produce reports on their patients when they don't even know the outcomes. They don't even personally know the outcomes they're producing for their patients outside of margins, right? So then we have these limited adoption of policy innovations because we don't have a setting to adopt the policy and we don't have a profession that really wants to adopt the policy. And then that lack of policy then just feeds right back into this cycle of field isolation. Now, I don't have a solution for this, sorry, but except for that I get to stand up here and talk about it because I'm a sociologist. But I do think this is a huge issue. This is a huge issue in terms of whether you want to whether you really want to move into the next millennia of organizational design and system design and workforce innovations in a way that actually drive population and patient satisfaction, population outcomes and patient satisfaction, or whether you want to kind of sort of keep tinkering at the edges. So, having said all that, now I've got you all riled up, or wait, no, that's me. I do want to talk about one example. So I'm just going to switch here to a case study. I've been doing work with the Willamette Dental Group, which is a large dental group in the Pacific Northwest, and they have this care advocate model that they've developed, and I'm just going to talk a little bit about it because I think it really spans a lot of these concepts that we've talked about. It's a nice just positive example going forward of the way that we might be able to think about retooling in the dental space that would then open doors and bridges for going into the medical space, or the health space, I guess is the better thing. So for care coordination, the idea behind care coordination really is that it helps patients and providers connect around patient education and treatment plan. There's a growing body of evidence about this in medicine, not so much in the rest of, or not so much in dentistry. For those of you who don't know anything about the Willamette Dental Group, it's a prevention-focused dental accountable care organization. It's been around since 1970. They have, I think, 53 clinics now across 3 states. They have about 400,000 enrolled lives in their system. So they are both a insurer as well as a provider. So you get insured by Willamette, and then you have access to all of their different sites, although most people obviously just have the main dentist that they go to. They've done a huge amount because they have, since the beginning, been a capitated system, so in that sort of global budget focus. They don't do much on fee-for-service, so they have this global budget that they're working within, and that's really allowed them to innovate. So they have implemented a system-wide electronic health record as of 2013, with a fully deployed dental diagnostic system. So dental diagnoses are mandatory within their system. They have embedded clinic decision support tools for both caries risk assessment as well as periodontal risk assessment that are mandatory for all of the evaluations that they do. And they work in a system where they both see Medicaid patients as well as private pay patients. And because they're in Oregon, and in their Oregon system, they are also contracted as a dental care organization with many of the coordinated care organizations which are the way the system is set up there to manage the Medicaid program. So when you look at their overall population, about 25% are at high risk for caries and 10% are at high risk for periodontal disease. They're not in all parts of Oregon, but they're throughout most of the populated areas. And they have a few offices in Idaho and a reasonable presence in Washington as well. So this is the site. So what they've done is they've really invested in the infrastructure to capture the data, to figure out which one of their patients are high risk, as well as to have comprehensive diagnosis and treatment histories on all of their patients as they go forward. What happens is when the patient comes in, they go through the clinical process, they get their health history, they have the clinical decisions tools automatically populate something called a proactive dental care plan. That's essentially a report card that the patient gets at the end of the visit that says what their caries risk is, what their periodontal risk is. It has their home care recommendations as well as their treatment plan if they need any sort of treatment, and they use that for comprehensive patient education at the end of the visit. So within this, it's a very different context for a dental organization, which is why I wanted to sort of outline that to you. I think it's fascinating in its own right. But in this particular, it was in this setting that one of the CCOs came to them and gave them a grant to help them better manage the diabetes. Now again, remember this is a Medicaid program, so they're looking at what they wanted to do was train up some care advocates that would identify the diabetic patients the Medicaid diabetic patients in their practice, get them in for their treatment, and then see, this was just a pilot, see what would happen over time. So the care advocates, they also provided clinical products, so they do aggressive prevention, so they would, if you're high risk, you'll get ClinPro toothpaste, you'll get chlorhexidine, depending on what the risk level is. But so they would go through this, 55 members completed the 2-year program. To the plan, the cost declined by 729 members year over year. And then the total visits decreased, so the diabetic patients needed fewer office visits for primary care as well as fewer patient stays. So it was seen generally, again, small pilot, but for the perspective of the care advocate, this all happened because they had somebody who, with grant funding, was able to actually identify the diabetic patients, identify the high-risk diabetic patients, and then get them into the clinical care that they could need, that then drove down these broader costs for the health plan. The care advocates themselves reported better personal connections with the patients, increased patient engagement, and then positive perceptions from the patients as well. So again, small pilot. Willamette doesn't ever do anything small. So they just decided, okay, we're just going to go full bore with this. So they have now put care advocates in every single one of their 53 offices. And instead of hiring a new provider to come in, they took their front office staff. They took the patient representative, the person that comes in that you check in with. They actually put them through clinical training. They certified them as care advocates. They taught them to do motivational interviewing, and they gave them tools where they can actually, in their practice, identify the high-risk patients and do personal outreach to them to bring them in. So so I just think it's a great example of how even in the dental space, if you have if you have the right tools, you can use those tools to really rethink how you use the workforce that you have and use that workforce to drive value. If you're getting your high-risk patients in and you're getting their treatment plans completed, or in this case, if they're diabetic or asthmatic or have other things, you're going to be driving a bunch of other health outcomes. Now, in this particular case, because their global budget, their bottom line is still dental, but if they can show to the Medicaid plans or to others that they are driving these broader cost savings in health outcomes, that obviously gives them a marketplace advantage. So not to mention doing the right thing. So they went through this whole process. We did a study on it. It's getting written up. And then the role itself, what they really did is the focus is on managing high-risk patients, monitoring treatment completion, and then following the exam as they go forward. So they've taken what used to be sort of a person at the front desk who was more of an administrative person and actually linked the front desk to the back desk, back to the front desk to create a comprehensive clinical care process that with the patient right at the middle of it. So we don't know what the actual long-term outcomes are of this. It's actually being studied in a dissertation, so give it 7 years. And then but actually they don't wait that long, so we'll see. But we did a very short post-implementation piece. They looked at by 2007, half their care advocates had been certified. Now all of them have. The care advocates on average were supporting about 7 to 8 patients at any given month. And then the interesting thing was the patients that they are actually supporting, 64% are high extreme risk and 24%. So over double, if you remember those initial numbers I gave you in terms of their risk stratification, they really are focusing on the high risk patients and trying to get them in, get their disease under control, get them onto maintenance out of the more expensive high-end care. This is the conclusions for the care advocate piece, and then I have one more slide. We also looked at going back to that quadruple aim. So what did this mean? Do the providers like it? Did the dentists like it? The managers and the managing dentists were extremely enthusiastic about this because it really they know who the high-risk patients are and they know how to treat them, but it allowed somebody to do the behavioral side, to really do the outreach and the personal touch piece. Also, a lot of those administrative staff are from they're all from the local community, and they're not doctors. These folks were working as front desk staff, so they're really able to connect with the patients that are coming in at more of a community level. The preliminary data showed the risk thing that I talked about, and then what we're really doing is tracking recall rates and risk status. So looking at those patients that have the care advocate touch and if they have a different trajectory over time in terms of improvements of health, and also the patient experience and patient satisfaction over time. So That, I think I'm just going to add that to the array of case studies that we are going to hear over the next couple of things. I think it's a really exciting one. And I think it also sets up a system like this. If you can do care management on high-risk patients and can identify that just in the dental space, imagine what if that person then was connected and integrated in a medical space. That's the kind of coordination, rather than the dentist and the physician spending their time on the phone, unreimbursed, talking about what might need to happen, but really having a system that allows someone else to mine that data, then act on it at a level that allows you to go forward. So I think key challenges from a workforce, or I guess not even just a workforce, but a broader perspective, is in terms of moving the workforce, redesigning the workforce in this value-based system, is really quality measurement. The electronic health records, the IT and the HR, that literally is the foundation of all of this, and we just don't have it in dentistry. We have pieces of it. Like I said, the diagnostic codes are pretty much complete. The DDS system, which is the dental diagnostic system, is harmonized with the ICD system. That's Snow Dent is harmonized with SNOMED. That work is being ongoing and done, so that system is there, but it's not currently translated into a user interface or into payment systems yet. So the tools are there, we're just not utilizing them. I think the issue of evidence-based practice and clinic decision support, going away from the individual provider kind of knowing best what's for the individual patient and actually using the evidence and science that we have and applying that, I think that's a big challenge. We did a study on the clinic decision support in Willamette, and interestingly, although people did say things, sort of snide things about it at first, the providers, the overall result was having the data there, the risk assessment data and it actually made their job easier. They were able to delegate more. They were able to decide what needed to be done because that data was there. Not so much, getting that data into the electronic health system, still a huge problem, still very time consuming. We haven't found great ways to do that, but having it available and out and quality reports on your thing has been, back to the quadruple aim, made their decision-making easier and actually made the teams work much more seamlessly together because they have a central place where they agree on what that looks like. I think there's lack of incentives. We talked about that. Definitely between dental and medical, and then if you had public health in there, it's what would that incentive structure look like to bring those folks together in a more comprehensive way? I don't know. And then I think strategic leadership. Really, I think this is where public health sort of shines, is in the strategic leadership, sort of saying, okay, we see what these system design problems are and we see where we might want to go with that, but how do we bridge that strategic leadership that we already have in public health and thinking about public health system design to actually doing this organizational support movement that needs to happen to move us up that value chain. And then finally, I always have to do my final pitch, oral health equity in public policy. If it doesn't matter at the federal level, if we don't have a Medicare benefit, if we don't have universal coverage, if it doesn't matter at the state level, if adult dental is optional in Medicaid, those things trickle down all the way, and you're working with the crumbs at the bottom. And until we really get oral health equity at the policy level, where oral health, vision, mental health, primary care, it's all necessary, it's all essential, and that's codified in some sort of a legal structure that then drives the payment and drives those incentive systems. Until we have that in place, we're going to be here in 10 years having the same conversation. My hair might just be grayer. All right, that's what I got. Any questions? Everyone needs a break.
Good job.
Great presentation. Great to see you. So something that is interesting to me, especially your slide going from the small fee-for-service up to systems type approaches and reorganization, which is not new to most industries. You've seen consolidation across airlines, banks, retail. One of the things that has dramatically changed in just my 15-year career is both the perspective of and the willing of new graduates to be in salaried systems, which may sound like a simple thing, but it really is one of the basis for Cleveland Clinic and all these models of Kaiser that we love, is that you you have a finance mechanism, but then you have a provider system, a system of delivery where people are paid a competitive salary with meaningful metrics and allowed to do the work. So could you comment on that, like in medicine, and how the transition to a more salaried, less widget-driven fee-for-service system has allowed consolidation and more ACO type movement, and how you see that with dentistry? Because I see that as being huge as we develop new systems.
Yeah, I mean, I don't know that I have an answer on like what causes it specifically. I think that millennial generation plus the amount of debt we're saddling them with is probably because of the completely unsustainable economic model of dental education. We could have a different talk about that. But I think that those things are really a couple of the things that are driving the openness to that. So sort of a cultural as well as a bottom line issue. I do think when you look historically at what happened in medicine, I mean, that really started in the 60s, and what was happening at the time when medicine was moving towards these larger consolidations was that the system was actually evolving at the same time that the doctors were trying to respond. So the hospitals were getting more powerful. They were trying to respond with contracting organizations, IPAs, and other things. But that infrastructure, that underlying infrastructure of evidence-based medicine, all of that evolved over time with that transition, and that transition was relatively slow. It took about 40 years, to kind of really move that transition along. If I had a crystal ball, which I don't, God, that would be helpful. I actually think that I see that transition happening now, and not just in the willingness, but in the organizational structure redesign. But because the infrastructure and the understanding of what that infrastructure needs to look like is already here and it's already in place, I think that transition is going to be much faster and much more disruptive. I think, the other question I have is that when you have a 40-year evolution, you can incrementally tinker and kind of get there. I don't know if we can do that in dentistry. I mean, it's very possible that some of these old models are just going to die off, and we're going to see things emerge that we can't even imagine yet, as our wonderful, innovative providers get out there and try new things. But I know, and that's got to be very anxiety-inducing for somebody who's invested for 40 years in a private practice and expects the sale of that practice to be their retirement, right? And then that practice isn't sellable anymore. And what do we do with that? Maybe it gets sold to to a dental service organization, or maybe it gets repurposed in some way. But I think that that's also a lot of what's causing the anxiety. So when you see the dental students, they're smart. First of all, they got $250,000 to $350,000 worth of debt. Last thing they're going to do, unless their dad owns a practice, is go into private, go take on additional debt. But I think they also see that transition coming, and they don't want to invest in the old. They want to put their feet in the new, and so that they can evolve in that space.
And this is the right audience to ask this, because I don't know. What has the dental service organizations learned around business, and is that working? I don't see them often at the table talking. I don't know if I've ever talked to anybody working directly in the DSO upper level management, but
I mean, the Willamette is a DSO. That's one. They have 53 offices. And the DSO, we did a report. If you go to the Oral Health Workforce Research Center, which is a HRSA-funded grant I have, we have a whole report that we did on DSOs. It's so new that they're all taking very different forms. Some of them see Medicaid, some of them don't. Some of them are just de novo. Some of them are, bringing up practices. And also the spread is hard because the variation in state practice acts and the way the businesses are run. So I know a number of years ago, what was the clinic in Alabama? Sorrel, that was sort of like, oh, this might be the model of the future, but that it never really went anywhere, and I'm not sure why. But that idea, I mean, it's still there, I think, but like in terms of like, taking off and being the thing everybody does, the question then becomes, okay, what is actually translatable and what's not? I do think that if you just look at the data on growth, the DSOs are growing very fast, and so that is the growth area in terms of an organizational model, but it's still primarily dental only. I mean, you've got Kaiser, you've got Health Partners, you've got a few places that are doing a much more of an integrated model, but they were doing that already. So it's hard to say. I don't have my crystal ball, but if I was a dental provider coming out, that's where I would want to work. I would want to work in a setting like that, where then my future is where I'm building into the future of where that volume, patient volume, not provider volume, but also having like a group. Like that's what the millennials want. They want to, they don't want to just be alone. They want to have a team. They want to be excited and interested in new things. And I think that gives them some of those opportunities that just kind of like camping out by yourself doesn't. So it doesn't solve some of our issues in rural, not yet. Maybe it will. It's hard to say. Yeah.
Thank you. That was a great talk. And it was also really interesting to get a sociological perspective because it really is quite distinct. I want to second your comment about equity and getting to have the public programs cover dental care. I think it's also important because that's where a lot of the innovation's happening through CMMI, but also Medicare drives a lot. I know it's no longer the biggest payer, Medicaid is, I mean, in terms of covered lives, but because it's a centralized payer, it drives so much in the health system. So I think that's very important. And I don't know what the policy discussions are, probably not under this administration, but preparing for a future administration would be very smart. I'm curious about that wheel of isolation because it was really interesting and also a little bit daunting. And I don't know enough about the dental landscape. Can DSOs and some of these other forms kind of shake up that isolation and be a counterweight to some of the intransient kind of stick in your lane and don't change kind of mentality?
I mean, honestly, at this point, I think it's the only thing that actually does have that power. Medicaid is seen as a second choice provider, and we don't have Medicare, so we don't have the power of the federal payers in driving innovation the same way that we've had in medicine. I mean, they're just begging them to take it. They don't have leverage over the providers. I do think that you are going to see that. And one of the other things you saw in medicine as that transition happened is sort of this differentiation between the providers in the field sort of doing the day-to-day work and what we would call sort of the physician elite, or the folks that are the thinkers, the ones in the academic health centers sort of trying to, come up with these new models and redesign. I don't know. I work in a dental school. I would call myself elite. I don't know, but but I don't know that we have that same cadre of folks in dentistry, and also the context is different. So is it again just dental, or are we looking at a cadre of people who are thinking more broadly about health system redesign that is always integrating dental into that and making sure that the dental providers are there at this space? But I think you can see that in medicine, and I think this DSO structure, remember I talked about that strategic management, it provides a space for that doesn't exist in the old model, and that strategic management space is going to be where that innovation and that vision happens. That's going to drive the next round of things. So, yeah.
Great job, Beth. I just want to address very quickly the DSO thing. I'm on the board for the dental
You should know.
Dental service, yeah. Getting old sucks, I'll tell you that. PDS, the Pacific Dental Services Foundation. I'm on their board. And what PDS is doing as one of the largest DSO, 700 offices around the country. And it is for profit, but what we're doing now, starting April 1st, they're opening their first not-for-profit Medicaid patients with special needs. So it's a focused special needs practice that has been designed by special needs experts, and it's going to be not-for-profit. It's the first one, and I think that's, I'm really excited about it from the foundation perspective, because it gives them an opportunity to see, wow, we can really do this and make a difference. And as Beth said, they've got the opportunity to do it. They've got a couple of integrated practices, California, Tennessee, Texas, here somewhere. And Colorado too. So they're trying to develop. I know Steve Thorne, the CEO, is really into the integrated model and is really want to go in that direction. So we may see, I think the DSOs are a catalyst for change. Thanks.
Thank you so much, Dr. Mertz. We appreciate it. One more round of applause.